Now we will go to how to do OFA. So it means what are the drugs we can use for the molecules we can use for the opioid-free anesthesia. Are these molecules as useful than other molecules like opiates, for instance? And do we have many studies demonstrating that the use of OFA is extraordinary? Or okay, and it's my pleasure to introduce Hélène Belleuil from Rennes, and she will speak about the molecules that we use in OFA. So please, Hélène.
Thank you, Xavier, for this introduction. So here we go. If you want the evidence based on OFA, you have everything on this slide. It's not easy to read, I agree, but everything is in there. So this, since 2006, the first study, so all these are randomized controlled trials. Since 2006, there's been 10 studies. As you can see, the number of patients in those studies are quite small, and they all use dexmedetomidine. So some of you might say there are other studies. Yes, but I just selected the studies where there's really a group without any opioids, because there are a lot of studies, if you look into the literature, that are calling OFA procedures in which you still have opioids. So these studies really compare typical general anesthesia with opioids to a different protocol, and instead of opioids, they use dexmedetomidine, alpha-2 agonist. In here, you can see that doses are very different from one study to another, different type of surgery, and the results. So the results, most studies they all go towards the same result, which is reduction in pain, reduction in opioid consumption. In terms of side effect, of course, as we all expect, as it is expected, there are some cases of bradycardia and hypotension. But if you compare with remifentanil, sometimes the bradycardia comes with remifentanil more than with dexmedetomidine. So it's not always the case. So within all these studies, I'm going to present to you in details just 3 of them. This first one is after spinal surgery. I chose this one because it's very well done and it's methodologically rigorous. So 2 groups, 50 patients, one group had remifentanil, the other group has dexmedetomidine. The rest was the same in both groups. In here you have the pain score in PACU and afterwards. And as you can see, even if it's in white in here, you can see that in that group, the group dexmedetomidine, patient had less pain throughout the whole post-op pathway. And not only they had less pain, but it was with using less rescue analgesics. As you can see in here, in the dexmedetomidine group, patients barely need rescue analgesia. And of course, if they need less rescue analgesics, that means they needed less opioids, so it's less PONV. As you can see, there is almost no PONV in that group compared to this group with a normal general anesthesia with opioids, where there is a lot of PONV. 2 other studies that I chose because they are really showing I think for the first time, a clinical benefit that is really meaningful to the patient, because studies showing just a reduction in opioids, morphine sparing, most of the patient would not see that. If you're sparing 10 milligrams of morphine in 24 hours, that doesn't do any good to the patient. So these studies showed a real clinical benefit for the patient, a meaningful benefit. First one is this one in bariatric surgery. One of the studies with the most patients, 120, randomized controlled trial, and they compared 2 types of anesthesia. One that would give a lot of PONV, I agree, but still, so the GA with gas and opioids. One with TIVA using propofol, ketamine, and dexmedetomidine. Upper scores were identical in both groups, and as you can see, there was a very dramatic reduction in PONV, 17%, and the patient who experienced PONV had less severe PONV, so real benefit for the patient. The 3rd study is a recently published study coming from Belgium. You know that in Belgium they have a history of OFA. They've been doing it for a long time, at least much longer than us in France. And finally, they published some of their results. So here is one of the study. 50 patients, another methodologically rigorous study, RCT, bariatric surgery. Comparing one group having opioid anesthesia with propofol, rocuronium, and sulfentanyl, and a group with OFA, and instead of sulfentanyl, they put dexmedetomidine, lidocaine, and ketamine. And the primary outcome was the Q40 score, which is a score of satisfaction of the patient, comfort and satisfaction. Patients were more satisfied in the OFA group, but you can also see that, like shown before, there was less pain, a lot less pain, and less morphine consumption. And what's interesting is that they look at other side effects of morphine. There was less hypoxemia, respiratory depression, and less PONV, and it's a very big difference if you compare the numbers. So clinically meaningful for the patient. So is OFA the anesthesia of the future? Like I've been asked this question many times. Is it the future of anesthesia? To me, I'm very enthusiastic, and it's very interesting to work on OFA, but there's still a lot of questions that are unanswered. First, the safety. We know we can have bradycardia, but to which level? How? Patricia already talked about that. What can we monitor when we do OFA? How do we monitor analgesia and depth of anesthesia? All the monitors that we're using today have never been validated in OFA. The proof, the evidence-based proof. So as I showed you, there's some studies showing morphine-sparing effect and reduction of some opioid-related side effects. But what about using OFA in a fast-tracking project? The hypothesis that, of course, if we don't use opioid, we're probably going to have a reduction of hyperalgesia and then a reduction of persistent pain after surgery, but this has never been shown. And finally, is OFA for all patients? One more time, I don't have the answer to this. Of course, we can right away make the hypothesis that obese patient with respiratory disease, patient chronically treated with opioids, or drug addict would have a benefit with OFA. But one more time, this has never been shown and needs to be shown. So we need to work. There's a lot of work to be done. And I'm going to end this presentation with this. There's one study going on in France called the POFA trial. It's 10 hospitals and comparing two types of anesthesia, an opioid anesthesia versus an opioid-free anesthesia. And the criteria is composite with postoperative ileus, postoperative cognitive dysfunction, and postoperative hypoxemia. Voilà. So we'll have the results soon because it's almost finished. So I'm hoping that within the next 6 months we can show you the results. Thank you.
Thank you, Hélène, for this very interesting focused on how we can do opioid-free analgesia, what kind of molecules we can use. Immediately, the first questions arriving is, you use different kind of molecules, right? So what can you expect about the supraddictive action, perhaps antagonist action in some effects? Because the fact to use lidocaine, ketamine, alpha-2 agonists, perhaps beta blockers, magnesium, etc. in the same patient, are you sure not to create some mixing problems in the PK/PD profile of the drugs?
Well, first, I'm not sure. No, I'm not. So this has never been studied. It's true that if you look at the history, we added one more molecule each time we had proof. So first we started adding ketamine, because ketamine was anti-hyperalgesia, and everybody started doing ketamine. And then we added lidocaine, because lidocaine, there's a lot of proof and evidence-based proof showing that it's it's an analgesic, and it can spare morphine when you use lidocaine during surgery. So, and then now we're adding dexmedetomidine. I agree with you. So first of all, I want to say, if you use dexmedetomidine, you don't use beta blockers. Let's be clear on this. Let's be clear on this. But we use dexmedetomidine because, as Patricia said, if you want to do opioid-free, we use opioid mainly not for analgesia. We use opioids for hemodynamic stability. So if you want some hemodynamic stability during your GA, this is what we want, then we need to replace that with another drugs. And alpha-2 agonists are the good drugs for that, for the hemodynamic stability that you need during surgery. But I agree with you that mixing all these molecules, and I know some people that are even mixing them in the same syringe.
Yeah, sure. I know that.
And I don't know if it's a good idea. I have no idea, no answer. I don't know if you can do that because it's never been studied. So maybe we can be confronted to side effects because of the mix of these drugs. And for example, when you use magnesium, but Patrice would talk about it, we know there's a risk of hypotension. You have that risk too with alpha-2 agonists. So need to be careful with the doses when you mix all these drugs together.
Okay, good answer. So another important point, this is the question about when you do that, you expect to limit the risk of hyperalgesia, mainly of opiates and mainly of remifentanil, if we speak about that. But it is important also to secure in the patient the hemodynamic stability because we don't have any opiates. So now you have to secure that. And are you sure that with, again, the mixing of these drugs, you can stabilize the hemodynamic profile in the patient?
I would say yes, mostly yes. It's not always the case, but mostly yes. First, Patrice is going to show you there's some literature about the hemodynamic stability with magnesium sulfate. And from my experience, and I guess for the experience of the people in here are doing OFA, you can have a hemodynamic stability with using those type of protocol. Of course, it's not always the case. We all had some bradycardia. We all had sometimes some hypotension or hypertension, because you can have hypertension. So it's not perfect. Nothing is perfect. But the vast majority of the time, in the vast majority of patients, yes, you have hemodynamic stability during the GA, and actually sometimes it's much better than with opioids, because it's like this. Your anesthesia profile is like this.
Okay, the last question is, it's a dual question. Is there any evidence about the use of clonidine? You speak about a lot of Dexmet, because Dexmet, it's a more modern approach of using alpha-2 agonist. And the other question is, have you any idea, because you stabilize the hemodynamic profile of the patient, you can expect to stabilize also the sympathetic effects of the surgery. Have you some evidence of decreased complications in the patient with using OFA? I know the answer, but it's only to expect to have some answer for the colleagues.
So first about clonidine, so I mostly present dexmedetomidine because I think he has a pharmacokinetic profile that is more favorable for OFA because the half-life is much shorter. But there are some publications with clonidine, and a lot of people in the world are doing opioid-free anesthesia with clonidine. So yes, you can do it with clonidine. I personally don't have the experience with clonidine, but you can do it. You still need to know exactly what you do because clonidine has a long half-life.
Sure.
So when you start with clonidine, you need to know not how to use it, otherwise your patients are going to be sedated for a long time in post-op. Second question about complication. Of course, we don't have any data, but one answer to this is that would be first the trial that I showed you. The other answer is that when we've been using OFA for quite a while now, you have that feeling that, yes, at least in PACU, we don't need oxygen in a PACU because people don't have any respiratory depression. So that's one first thing, which is major. So there's a feeling that maybe we're going to have less complication related to anesthesia with OFA, less PONV, less respiratory depression. But one more time, it's not totally proven what I'm saying right now.
Okay, thank you very much, Hélène, about that very interesting topic of using different kind of molecules in the OFA management of the patient.